Good afternoon, everyone. Welcome. Thank you for being with us today. It's a pleasure to have you guys here. Today, we're going to talk about the SDX system for respiratory gating. And our speaker is Thomas Iverson from Samaritan Health Services. He's going to speak about the clinical lessons learned while using SDX for DIBH. Thomas, you have the mic now. And anybody, if you have any questions, you can write them in the chat and we'll be answering them at the end of the presentation.
All right, thanks, Annabelle. So hi, everyone. Thanks for coming to see my presentation. Like Annabelle said, I'm going to talk about our experience using SDX for DIBH. I tried to make this presentation pretty clinically focused, not so much on technical things. Feel free to ask any questions. We'll have lots of time at the end, answer questions. And just a quick disclaimer, I'm a little loopy from a lack of sleep. I have a small child who keeps me up all night, every night. So I put pictures of them in the presentation just to kind of a peace offering. So let's get started. All right, so here's just a quick outline of what we're going to cover today. I will give you all an overview of our general practice when it comes to gating. I'll go through a pretty quick sim and treatment workflow, and then we'll spend most of the presentation going over lessons learned. These are just essentially nuggets of wisdom. I tried to organize them into three main categories for simulation planning and treatment. But as you'll see, a lot of the lessons overlap, and some of them are specific to SDX, some of them specific to gating, and then some are more general, just clinical lessons. And like I said, at the end, we'll have lots of time for questions, so please don't hesitate to ask. All right, so Samaritan is a small community center located in Corvallis, Oregon. We treat about 800 patients a year, and about an eighth of them, I'd say, are DIBH patients. We have two LINACs. We have a Varian Edge and Vital Beam. For those of you who don't know what those are, an Edge is a true beam with micro MLCs, so more specific for radiosurgery treatments. And then a Vital Beam is a true beam, kind of like a budget true beam that does not have FDA clearance for use with Vision RT. And then we have a Canon CT scanner. And then in terms of staffing, we have 3 physicians, 2.5 dosimetrists, 2 physicists. We are all Varian shops, so we're ARIA Eclipse, and then we also have MIM. So what are we treating with DIBH? Nothing surprising here, mostly left breast, chest wall patients. About, I'd say 90, probably more of our left breast treatments are DIBH. We do lung and liver SBRTs as well with breath hold, and 2 to 5 a month seems about right. We usually have someone on treatment that's being gated. And then we do get random other sites that will do breath hold on, an occasional right breast, we've done a kidney as well. And just as a disclaimer, I do everything with inhale breath hold. We don't do exhale, and we don't do any like gated treatments where they're breathing and we just treat during a certain part of the cycle. It's all breath hold. So what are we using to treat? Obviously, we have SDX, or I wouldn't be here talking. So we have two devices. One we have one gating box hooked up to the edge, which controls beam on and off. The other one, the SDX, is separate from the machine. We also have Identify, which is a surface tracking package that we could use to treat breath hold. And then for our CT, we have an on-site system, a laser belt that we'll use for 40 CTs and the occasional breath hold scan. So I joined Samaritan in March of 2020. When I got here, they already had SDX and were treating left breast DIBH. In the fall of 2021, we got the gating module and started doing SBRT breath holds. And we have all these devices mostly because we're a small community center. So when you get the budget to purchase things, you purchase as much as you can. So for those of you not familiar with SDX, I'll give you a quick primer on how it functions. SDX is a spirometry-based system, so it's actually measuring the volume of a patient's breath. They wear glasses where they can see this screen here, and it's mirrored outside the room for the therapist. So essentially, a patient will breathe, it measures their trace, and they have to hit this gray box 3 times. Then the therapist can turn on their thresholds, and the patient gets up and in it, and then you treat. And if they fall out, it makes a noise, you stop treating. And with the gating box, this is all automatic and triggered through the box. But then on our VB, it's completely separate, so it's all manual gating. If you are interested in learning more about how SDX works, there's lots of other presentations going into more technical details, and they're fantastic, to give you a good understanding of the nuts and bolts. So here's just a quick overview of what a typical treatment would look like. See, they have multiple breath holds. You do a lot of resetting, get them back and breathing normally. And I'd say from our experience, 6 or 7 breath holds is pretty normal. Yeah. So how do we train and qualify patients for DIBH? If a left breast patient comes in for consults, we have them watch a video on breath hold, and then also give them training instructions. We encourage patients to go home and practice holding their breath. And then they'll come in for simulation and we evaluate them. So patients have to hold their breath for about 20 seconds, and we have them do lots of breath holds, make sure they're able to consistently reach the same level, and it's not going to cause issues like coughing, uncomfortableness. So for simming, it's a little complicated just because we have a lot of devices. So for all left breasts, we do a free breathing and a breath hold scan if they can do a breath hold. And then the physician will look at both of them and say, I want to do breath hold. And I'd say 90% of them, they're going to pick the breath hold scan, even if they look pretty similar. Kind of a LARA principle there. And then for lung and liver SBRT, it's a little bit different. We'll do a 4D CT, and the physician will look at it and determine if we want to do breath hold. If we do, we have to set them up with the SDX and then do a breath hold scan that way. And yeah, I'd say lung is not too common unless it's near the diaphragm. Then for liver, they seem to err on the side of doing breath holds more often than not. And then for treatment, if they are on the edge, we will do their breath hold using Identify. And then SBRTs are treated with SDX with the gating module. And then on the VB, they are treated using SDX. And it's worth noting, since these machines are not matched, you can't just swap people back and forth. It requires replanning. But in a pinch, we can move VB patients to the edge if we replan them. We have successfully used SDX to acquire the surfaces for Identify for breath hold. But that's really if the VB goes down, we have a backup plan for people who need to be treated. I've also started turning Identify on when we do SDR treatments just to see how well it tracks with the SDX, and they have been correlating surprisingly well, which is always a confidence boost that you are doing things correctly. All right, so now it's time to go the lessons learned for simulation to start. So the first lesson is to schedule generously for your DIBH sim appointments. You want to give your patients a lot of time. During consult, patients are kind of bombarded with information. So you may tell them about the breath holds, but if they're going to retain that fact or not is kind of a flip of a coin. A lot of patients won't practice because there's a lot going on. So it's hard to expect people to make this the priority in their life. So you want to give them a lot of time to come in, re-explain the process, have them practice holding their breath. And you really want to take your time on this step, getting them comfortable and everything, because the more time you take and the better they are at holding their breath, the easier everything else downstream becomes. So for DIBH appointments, you want to schedule some extra time. I think we do an extra half hour for our breath hold sims. I'm going to move the poll off the screen really quick. Okay. Next lesson is that our patients are human. So with all gating devices, they're kind of designed around a phantom. That's something that can breathe consistently and the same amount forever. Our patients are not phantoms, they're humans. And so what you'll see is that breathing regularly is kind of an anomaly, especially for the types of patients we're dealing with. We're dealing with people who are sick and nervous, and for lung 4Ds, people with reduced lung function. And people, they will complain about everything. Some people will find the SDX not comfortable. So you really have to work with your patients, get them comfortable. Again, this kind of goes with scheduling more time. You just want to give people time to get used to the system. And you want to have multiple approaches to coaching for patients. We were having an issue where we had a lot of patients for our 4Ds. They were falling asleep on the table. So their breathing would be fine, then all of a sudden it just completely changed. So we found that if you just have voice coaching going on, they can follow along and they stay awake for the 4D CT. The next lesson is to consider your immobilization. So this is something we kind of learned the hard way. We purchased a new wing board and then came to realize that it was too bulky to have the wing board and the SDX on the table at the same time. The SDX is a physical device. It's got to sit by the patient's head, and then the neck has to come down into their mouth. So you need to, if you're looking at new immobilization or your current immobilization, you just need to remember your breath hold patients and SDX. Make sure that they will be compatible. We also, you need to consider the fact that since it's at the head of the table, we've been indexing everyone down a spot to accommodate the SDX. So if you have like an inferior liver treatment, you just need to be cognizant that you will actually be able to treat them on the machines. So far, we haven't really had an issue, but it's something that's on our mind because you don't have a lot of wiggle room there. And then also, if you're using vac locks, just make sure you have a spot for the SDX. The last thing you want to do is create a vac lock and then realize you have to put it on the table somehow. And so you're either messing with the bag or you're sliding everything down to fit. So the last sim lesson, this one's pretty important. It's Alara, not Allah. So reasonable is huge for breath holds. You can technically do breath hold on everyone, but there are definitely patients that it's not beneficial for. You'll have people who, after they hold their breath, they cough, and then they're moving because they're coughing. And so, yeah, you can breath hold and maybe move the heart away, but is it worth it now that you have to reset them up because they've coughed and moved and everything? And so this is a discussion with your physicians. I found for us, they like doing breath holds. Obviously, it is beneficial for a lot of people, but there are some people where you're going to actually cause more issues than solve by making them do breath hold. And it's kind of, if you have some clearly defined metrics, that can help. But I found for us, if you have these hard and fast rules, basically they just get ignored. So if we have issues with a patient, usually you just bring the physician back and talk to them and ask them what they want to do. I always ask them, if we could do breath holds, but we're probably going to have to end up rescanning and replanning them down the road. Are you okay if they take a break in the middle of treatment? They may be okay with like some left breasts doing that, but for SBRTs, it'll be essentially it's not worth the effort. And just be prepared if you're starting a program and it's new for you and the physicians that you may have to do some comparison plans early on. So you may acquire the breath hold scan, do a plan on it, and a free breathing scan as well, and have your physician look at it. That's it for simulation. Now we'll talk about planning. First lesson, this one's a pretty big one in my opinion, is to limit your beam on time for breath hold patients. So you have to be aware, we're giving them radiation. Very common side effect of radiation is fatigue. So you're asking a patient to hold their breath, 15, 20 times during treatment. They may be able to eke their way through for, a couple weeks, but then towards the end of their treatment, they're getting tired. It's just going to get tougher. So it's a little bit of a balancing act with dosimetry. If you really need an extra beam or some extra MU, you may get a prettier plan, but is it realistic? Is it treatable? Those are questions you need to be asking for DIBH, because yeah, you can add a couple of beams and lower the heart dose by 50 centigrade, but if the patient's not getting through treatment and they're wiggling, then you're not giving them any benefit. I don't really have like a hard and fast rule for however many beams you have, because again, I think rules, if you set rules, they just get broken. But you can anticipate that for imaging, they'll hold their breath 2 to 3 times, and then just every 20 seconds of treatment time is another breath hold. Some patients will do a lot better than that. Some will do a lot worse. And it's just experience. The more you do it, the better you'll understand. And also have your dosimetrist talk with the sim therapist about the patient, because the sim therapist will know if a patient can handle doing some extra breath holds. If they were really good in sim, chances are they'll be fantastic on treatment. So here's just an example of what can happen if you have overplanned for a patient. You can see this looks exhausting just looking at it. And it's hard to pick out the individual things, but you can see towards the end of their treatment, here, let me turn on the laser pointer. Towards the end of treatment, you could see she would get in and then just slide out because she was too fatigued to continue holding her breath. And so this is kind of what you're trying to avoid with patients. Next lesson for planning is to check clearance. This may seem obvious, but you need to be aware of where the head of the SDX will be in your scans. You can see here that it's our clearance check software is saying it'll clear, but actually, I know it's a little hard to tell, but the head of the device is cut off in this scan. So if you went ahead for treatment, you would have a collision. Probably more important if you're using couch kicks, but it will come up. You just need to be aware of it. If you have clearance checking software, it won't always catch this. And you do have like a little bit of wiggle room with the neck of the device and adjusting it, but I like to avoid that as much as possible, because once you start moving the device in the patient's mouth and kind of moving their head, you get a lot of patients who say that they can't hold their breath as deep, and they have difficulties with that. And again, this is something that will come with more experience. I think, especially early on, if you're using the SDX, you may have some issues, but once your dosimetrist kind of gets a feel for it, it becomes a little less important. Okay, and then the final planning lesson is to label everything. This kind of has 2 uses. So first, it will get everyone on the same page, remembering that it is a breath hold patient and to treat them as such. And then secondly, it's just documentation. So if, someone forgets, like commonly, like a physician will forget to put breath hold in the script, you have a ton of other places you can look to verify that the patient is breath hold, instead of relying on just like maybe the plan name. Then you have a he said, she said thing. And then again, it gets you thinking. So if a dosimetrist brings in a scan and has to name it breath hold, then they're ensuring that they're bringing in the correct scan. It's just a double check there. And then it's on their mind when they're planning, so they can kind of think, well, if they're breath hold, I probably shouldn't put 10 beams on this person. And then for the therapists, for scheduling, it just gives them the awareness that they're breath hold. We need to just make sure the device is available. So for us, we have to share a device between 3 rooms, so they need to make sure that when they schedule, it's not at the same time as 2 other breath holds. And yeah, just labeling everything will reduce your potential for errors. All right, so finally, we're going to go to treatment lessons. I just have a picture of our probably hardest working therapist up there. First big one, this one's similar to the SIM one. You want to give yourself some extra time. This is especially important the first week of treatment. Your patients are usually nervous. They won't, a lot of hit the same breath hold as in SIM, and that could be for a ton of reasons. Usually there's some setup issue that you can fix. And after about a week, you know, the patient has the whole routine kind of figured out, and therapists do as well. So then it becomes less of a whole process. And a lot of patients, yeah, after that first week, they do fine. You will get patients who just struggle continuously, no matter what you do. And those are patients you just want to keep an eye on, because they're going to be your problem children. That kind of leads into the next lesson, is to foster a safety culture. So this is extremely important. You need to make sure that your therapists feel comfortable coming to you and voicing concerns if they think a patient's struggling and won't be able to make it through treatment. It's really good to know that ahead of time so you can plan for it, than to find out, you know, halfway through a patient's plan, they've gotten 2 beams out of 6 and now they can't hold their breath anymore. You want to avoid scenarios like that. And then this is especially important to, if you're doing manually gated treatments, there is no hard stop for turning the beam on and off. This is all human driven, and human error is probably the most common source of error in departments. So you need to make sure your therapists are comfortable letting you know if they do accidentally beam on while a patient was free breathing, so you can determine if there's going to be any negative consequences to that. And it's important to have your therapist do a timeout before they beam on for DIBH. And this goes hand in hand with the over-labeling, so they'll know it's a DIBH appointment. They'll see it in the plan name. They'll see it on the field's names, so they're less likely to forget, especially when they're in a rush, because they're seeing it everywhere. And so it's kind of triggering their mind to, hold on, we're doing a DIBH patient, let's slow down. And then just finally, this is important too with new staff, because they're still getting the hang of everything. So you want to really make sure that they're timing out. All right, next lesson is plan on replanning. So no matter what you do, you're going to have patients who can't do a breath hold anymore halfway through treatment. I think it's unavoidable. There's all sorts of reasons. Anecdotally, I feel that this happens more often if like a patient gets sick halfway through treatment and takes a break. For whatever reason, they'll come back and then they just can't hit their thresholds anymore. A lot of this could be due to patient fatigue as well. So you need to have a plan in place for what to do when this happens. Kind of 2 big scenarios. The first is they bring them in and they maybe get through imaging, but they haven't started treatment. The patient's struggling, the therapist will grab you and let you know and ask you what you want to do. You need to have basically a decision tree in place. Are you going to take them down? Are you going to rescan them, rebreathing, and replan them? Are you just going to send them home and try again tomorrow? So it's good to have a sense of what you want to do in these scenarios ahead of time. What are you going to do if they've treated half the plan and then the patient can't continue? Basically, if you have this kind of figured out ahead of time, when it does happen, you won't be caught off guard. You can be confident in whatever decision you make because you've kind of given it some thought. And then just for reference, we do a quarterly review of all the replans we do. And I'd say we usually have one patient, maybe two, that we have to talk about we replanned because they couldn't do breath hold anymore. Okay, so the final lesson is to understand your system. And this is maybe not so much a burden on you. Maybe your IS has a huge say in how your system is set up. For us, our IS wants to control everything that touches a computer. So we have limited access to what we can do. But you're gonna have crazy, weird, unpredictable things pop up. And it's very beneficial if you can test exactly what the issue is. Because from what I've found, if you do IS and say it's not working, they're just gonna point you to the vendor and be like, it's their problem. They don't want to do anything. They want everyone else to tell them what to do. So it's really nice if they have documentation of how everything's set up. There's a lot of staff turnover, I've noticed. So the same person who sets up your system probably is working in a different department, and you'll get a whole different person helping you troubleshoot. I'll give a quick example of something that can happen. One morning, our therapist came in to do QA and turned on the SDX and got an error that the patient database could not be found. So they called me, and I basically, without looking at it, I assumed we had a network issue, that it couldn't connect to the database. So I told them to call and have them look at the connection, make sure everything's talking. I don't hear anything for a while. I come in, and luckily, very luckily, we had someone from IS who actually helped us set up the system, knew what to do, and was able to get us connected. But what happened was, during the night, someone else from IS had just changed the, migrated the server that our patient database was on and didn't tell anyone. So the SDX was just pointing to nothing. And it is a really scary situation, especially for the edge, because if SDX is not connected, the edge, the interlock box won't allow treatment. So we wouldn't have been able to treat patients. And that's something you can't really plan for. You don't expect people just to be messing with your server, but when you don't have control of it, stuff like this can happen. So it's just important to have IS document everything, so you can try to fix these errors when they pop up. So that's it. That's all I had to talk about today. I hope that was useful for you all. So now if there's any questions, I'm happy to answer them.
Thank you, Thomas. Thank you very much. It was a very insightful presentation, very honest about the clinical feedback. So we do have a couple of questions. The first one was, do you use the SDX in simulation for breast DIBH? how do you get the range otherwise?
Yeah, so we do use it for our breast DIBH in sim. I'll go back to the slide. So actually this, go all the way back. So this screen here is the simulation screen. So when a patient comes in for sim, this is what they'll be seeing. And you can kind of see it's a little small, but down in this bottom right, this is where you set all your thresholds. You have control over the level, the width of this band, and then also the width of the gray band.
And we have some other questions. The first one is, for your external, do you include the spirometer mouthpiece in it? I was curious to see if it matters for photons. I'm only used to using it for protons, and it helps ensure we haven't used beams to go through that area.
All right. So we do not scan up the, usually we don't scan this high where we're including the mouthpiece and the whole spirometer. Like where was it? Like this image showed, we don't increase our field of view to include it because usually it doesn't matter for planning, except for in terms of clearance. But we just avoid having angles that go close to the mouthpiece. I don't know if that was a good enough answer, but.
We do have another question from the same person. She asked, do you do backup FBAVG plans for each patient?
So backup free breathing average scans, I'm assuming.
Yes, I'm assuming that's the question.
Yeah, we don't. Well, so for all left breast patients, we do a free breathing scan. And for all SBRTs, we do a 4D and a free breathing scan as well. So we don't do an extra one unless the physician requests to redo a free breathing scan. What we'll do is we'll bring the free breathing scan into Eclipse and if we need to replan someone to free breathing, we can use that scan.
Okay. One other question was, what is the average achievable mean dose to the heart using DIBH for 40 gray 15 session prescription? It's a very precise question. Very specific.
That's very, very patient dependent. I think we try to keep our mean, our physicians like it under 3 gray for the mean dose. I think our limit goes up to 5, but yeah, it really depends on your patient's anatomy, what you can achieve for that. And it also depends on your physician. They may be comfortable reducing your coverage a little bit if they're uncomfortable with the heart dose, or they may prefer coverage over heart dose. It's very physician dependent.
Okay, and then the same person asked, what are you doing DIBH for VMAT planning or used only for FIF tangential beam IMRT?
We have used DIBH for VMAT planning. I'm assuming this is just for left breast. For SBRT, yeah, those are all ARCs and VMAT. But for left breast, we tend to not use VMAT as much as possible. But we have done it, but I prefer having static beams.
Okay. We don't have any more questions for now, but feel free to use the chat if you need to ask anything to Thomas today. We do have
If you
some
have
comments
questions,
about the cute pictures.
good. I think he's pretty cute myself, but I'm a little biased. If you guys do have questions, feel free to email me later as well. I'm usually fairly responsive. I guess I'll just type my email chat. One.
Has SDX been used for proton therapy? Actually, I think I might get that question. Yes, we do use SDX for proton therapy. In the United States, we have now 17 centers using this system. And we do have also some proton centers overseas in Europe and Asia using this system. And we do have a comment of one of our users, Michel, who says that it works great for protons. So Michel is a dosimetrist. So if you have any questions about dosimetry, we can also have Michel answer those questions for proton therapy. And so Thomas, our speaker, shared his email address in the chat. Feel free to ask any questions, and you can also reach out to me if you have any questions. I will put you in contact with him. We have one question that's asking, what's your CT scanner brand?
Oh, yeah, that's kind of important. We have a Canon CT. We actually just replaced it, or just installed it a year ago now. But before that, we had a GE.
All right. So I see we still have more than 80 people connected to the presentation. Feel free to ask any question. And we do have a lot of people saying the presentation was great and that Thomas is fantastic. So I think you have a lot of admirers today.
Thank you. I appreciate that.
I still see 80 people connected, so I'm sure a lot of you have questions. Feel free to ask them in the chat. And if you prefer to have one-on-one conversation with myself or with Thomas, use our email address to send us those questions. We'll stay connected for a few more minutes before we close this presentation today. We do have two more questions. Have you ever treated an SDX in a head and neck mask used for mediastinum cases? If so, how do you immobilize the SDX so it does not collide in a gantry? That's a great question.
Ooh, that is a good question. Trying to think if we have. I don't remember anything, excuse me, off the top of my head. But if we ever had to, what I would probably do is just, you cut out the mouth for the spirometer, and then just have to be really cognizant of clearance issues.
So we do have one of our users from the New York Proton Center that says that they have done that. And I know there's another Proton Center, Inova Shar. They have been doing that. So if you want any feedback, Derek, about that questions, then you can definitely ask us. And then we have another question. Would you say that SGRT and spirometry are complementary in your practice? That's a very interesting question because we do have that inquiry very often. Do you think surface gating and spirometry can be used at the same time to do different type of jobs?
Yeah, definitely. For us, surface and spirometry, I think, have both their pros and their cons. Especially for like long SBRTs and livers, I think spirometry gives me more confidence that when they hold their breath, they're in the right spot. But yeah, I think I really like using them both at the same time for the SBRTs. I think it's interesting to note how they breathe. Yeah, definitely.
We still have 40 people connected. I'm sure we still have a bunch of questions here, so feel free to put them in the chat today. I do have one question for you, Thomas. Did you see a great change in the confidence and the procedure for the treatment since you acquired the gating module for automatic beam on, beam off? Did that make a difference in the practice on a day-to-day basis?
I'd say not a huge difference, mostly because we use the module for SBRTs, just because it's delivering so much dose with such tight margins so quickly. We didn't trust manual gating for that. We have done, I think we did a couple of left breaths over on the edge with the gating module, and it's pretty similar. Our therapists are pretty good about being on top of turning the beam off when they're out of thresholds.
Okay.
But it definitely, with the gating module, and we're kind of ramping up the SBRTs with breath hold. Our doctors are a lot more gung-ho about doing breath holds for anything they can think of.
Okay. All right, so I think we do have one more question. How did you manage to train your team members on several devices? Are they dedicated to one device?
That's a good question. They are not dedicated. They do rotate through. It's a lot of cross training. So essentially, the way we do it is you never have two people new to the device on it at the same time. So you always have someone who's been working with it a while, and they can kind of cross train people. Because you can do like group trainings, but the issue you have doing something like that is you can train everyone all at once, and then you have only 2 people using it at a time. And then depending on how their schedules work out, when they swap who's working on what machine, it could be, a few weeks before where they haven't worked with it. So they're not going to remember their training. I hope that answered the question.
Do you have a lot of turnover in the team?
Not too much. We do have students that rotate through, which honestly it's kind of helpful, because then our therapists are constantly training people, so they're constantly talking about the device. You always have they always have questions, and if the therapists don't know, they come to you and ask. So they're always training people and talking about the device and thinking about it.
Okay. Very good. All right, I don't see any more question at the moment. Like we mentioned before, feel free to email me or Thomas. Our emails are in the chat. If you want a one-on-one time to ask all your questions, we're going to close the meeting today. Thank you very much for being with us, Thomas, and for this great presentation today.
Yeah, thank you so much for having me.
All right. Have a great day, everybody. We'll see you on the next webinar.